بسم الله الرحمن الرحيم. أعزائي الطلبة، راح نبدأ إن شاء الله بالمحاضرة الأولى واللي تخص النيوروباثولوجي. هاي المحاضرة راح تخص malformations and developmental abnormalities or what is called congenital abnormalities. The developmental disability in general include one of the following things: maybe in the form of mental retardation, maybe in the form of cerebral palsy, maybe in the form of neural tube defects, or other forms of congenital abnormalities. The incidence of these congenital abnormalities is in the range of 1 to 2%. And here there is either failure of normal CNS development or there is tissue destruction. And these are caused by prenatal or perinatal insult, either prenatal or perinatal insults. The pathogenesis is generally unknown, and in general there is some interaction between genetic predisposition and environmental factors. The neural tube defects are the first group of congenital abnormalities affecting the neural or the nervous system. The congenital abnormalities affecting the nervous system included other groups. These are the forebrain abnormalities, posterior cranial fossa anomalies, Syringomyelia, and hydromyelia. The neural tube defects include anencephaly, encephalocele, and spinal dysrhythm, or what is known as spina bifida. And the spina bifida include two major abnormalities. These are the meningomyelocele and the meningocele. The forebrain abnormalities include polymicrogyria, megalencephaly, microencephaly, lysencephaly, also called agyria, holoprosencephaly, and the agenesis of the corpus callosum. The posterior cranial fossa abnormalities include Chiari malformation and Dandy-Walker malformation. The first group of congenital abnormalities affecting the nervous system, and they are the most common by far, including the neural tube defects, and these occurs either due to failure of a portion of the neural tube to close or reopening of a region of the tube after successful closure. You remember during your previous study in the anatomy lectures and embryology lectures that the neural tube is formed from the ectodermal layer. This is the notochord, and this is the neural plate. And you can see that the neural plate at the start, it is formed as a thickening, and this thickening is later on will form neural folds. These are the neural folds, and later on these neural folds will close to form the neural tube. This is the fully developed neural tube, closed neural tube. So any defect in the closure of this neural tube or reopening of a fully closed tube will lead to the development of neural tube defects. It accounts for most of CNS malformations, and the etiology is unknown. Folate deficiency has been regarded or has been considered as one of the major risk factors for the development of neural tube defects. For the diagnosis of neural tube defects, we have two important techniques. The first is the use of an imaging method, such as ultrasound, or we can do a sample. We can take a sample of blood from the pregnant lady and measure the level of alpha fetoprotein. If alpha fetoprotein is elevated, this is an indication of the presence of a neural tube defect in the fetus. The overall recurrence rate for a neural tube defect in subsequent pregnancies have been estimated to range from 4% to 5%, and the most common form involved the spinal cord. The most common form usually involved the spinal cord. The first of the neural tube defects is the anencephaly. You can see this is a normal brain inside the skull, while here there is an anencephaly. The anencephaly is characterized by loss of the brain. So it is a malformation of the anterior end of the neural tube with the absence of the brain and the calvarium. The incidence is in the range of 1 to 5 per 1,000 live births, and most commonly it is seen in females. The forebrain development is disrupted, and all that remains is the what is called area cerebrovasculosa, which is a flattened remnant of disorganized brain tissue with admixed ependyma, choroid plexus, and meningothelial cells. The posterior fossa structures may be spared. The descending tracts associated with disrupted structures are absent. You know from your previous study that there are ascending tracts carrying afferent information to the brain, and there are descending tracts carrying efferent information from the brain, and these tracts are usually absent from the disrupted structures in case of anencephaly. In encephalocele, there is a diverticulum of a malformed CNS tissue extending through a defect in the cranium. It most often occurs in the occipital region or in the posterior fossa. In the lionencephaly, this is a rare neural tube defect that results in extreme bending of the head to the spine and is usually incompatible with life. Now we come to the most important neural tube defects. These are collectively called spina bifida, and they are either in the form of spina bifida occulta, in which there is only asymptomatic bony defect, or spina bifida cystica. If it contains a nervous tissue, CNS tissue, it is called myelomeningocele, and if it contains no nervous tissue, it is called meningocele. Neurological dysfunction is most often related to structural abnormality of the cord itself and also due to superimposed infection. Myelomeningocele occur most commonly in lumbosacral region, and the patient manifests clinical deficits referable to the motor and sensory function in the lower extremities, as well as disturbances of bowel and the bladder control. Now we come to the forebrain abnormalities. We have neuronal migration defect, polymicrogyria. This abnormality is characterized by small, numerous, irregular cerebral convolutions, and the gray matter is composed of 4 layers instead of the normal 6 layers. In lissencephaly or agyria, there is total absence of gyri, leaving a smooth surface brain, and these are associated with a number of well-defined syndromes. For example, Miller-Dieker syndrome, which is characterized by seizures, mental retardation, lissencephaly, and deletion in chromosome 70. In thanatotropic dwarfism or lethal form of chondrodysplasia, there is a large and hyperconvoluted temporal lobes, and in association with micromelia and chest and skull deformities. The forebrain anomalies also may include defect in the volume of a brain, either increase in the volume, which is called megalencephaly, or reduction in the volume, which is called microencephaly. Microencephaly is more common, can occur in a wide range of clinical settings in association with chromosomal abnormalities, and we have what is called fetal alcohol syndrome and HIV-1 infection in utero in association with microencephaly. Holoprosencephalon, here there is a range of abnormalities, from a severe case, which is known as cyclopia, which is usually incompatible with life, to very mild presentation that is compatible with life and even with adult life. It is characterized by incomplete separation of cerebral hemispheres across the midline in association trisomy 13, trisomy 18, and diabetic mother. Forebrain anomalies, there is agenesis of corpus callosum, and it is a common malformation, and there is complete or partial absence of the corpus callosum associated with what is called Batwing deformity of lateral ventricles. The patients are with mental retardation or in a clinically normal variant. In isolation, can be associated with wide range of other abnormalities or malformation. One of the syndromes that is characterized by absence of corpus callosum is Aicardi syndrome, which is an X-linked syndrome in association with chorioretinal defects and seizures. Posterior cranial fossa abnormalities include Chiari-1 malformation, in which the cerebellar tonsils extend down into the vertebral canal and may cause symptoms referable to obstruction of CSF and medullary compression. While in Arnold-Chiari malformation, Chiari type 2, there is small posterior cranial fossa, a misshapen midline cerebellum with downward extension of vermis through the foramen magna. There is hydrocephalus and lumbar myelomeningocele. In the Dandy-Walker malformation, there is enlarged posterior cranial fossa. The vermis is absent or rudimentary, and there is a large midline cyst representing the expanded roofless fourth ventricle in the absence of the vermis. Hydromyelia mean expansion of the ependymaligned central canal of the cord, while Syringomyelia is a fluid-like cleft-like cavity in the inner portion of the cord, and these lesions are associated with destruction of the adjacent gray and white matter and are surrounded by a dense feltwork of reactive gliosis. The cervical spinal cord is most often affected, and the slit-like cavity may extend into the brainstem, syringobulby. This is an imaging MRI picture showing syringomyelia or syrinx, and here we have what is called a cross section in the spinal cord showing hydromyelia, in which there is a dilatation of the central canal. These defects are associated with progressive evolution of dissociated sensory loss of pain and temperature sensation in the upper extremities due to early involvement of the crossing anterior spinal commissural fibers with retention of position sense and absence of motor deficits. Syringomyelia may be associated with Chiari malformation 1 and occur in association with intraspinal tumors and following traumatic injury. Thank you very much for your listening. See you in the next lecture.